In this video, we're going to talk about the events of the cardiac cycle and what happens when the chambers are contracting and relaxing. Before we start talking about that, we need to describe what the heart looks like before it starts contracting. And so before the atrial systole, which is going to be the first step of our cardiac cycle, all the chambers of the heart are going to be relaxed. So imagine the heart that you were looking at in the lab. That would be the heart when it's not contracting. So all the chambers are relaxed at this point. Blood is returning to the atria. It's returning on the right side to the right atrium from the systemic circulation, and on the left side to the left atrium from the pulmonary circulation. As this blood is filling the atria, it is going to passively be leaking into the ventricles through the AV valves. AV valves are the atrioventricular valves that separate the atria from ventricles. Okay, so the blood is leaking from the atria into the ventricles as it's filling the atria. Semilunar valves at this point are closed. If you remember, semilunar valves are the valves that are at the entrance of the pulmonary trunk and the aorta. So we have a pulmonary semilunar valve at the beginning of the pulmonary trunk as that is coming out of the right ventricle. And then we have the aortic semilunar valve when the blood is going to be entering the aorta from the left ventricle. And so these semilunar valves are closed at this point because the only time that the semilunar valves are open is when the ventricles are contracting. But at this point, ventricles are relaxed. There's somewhat of a tension on the chordae tendineae also when the ventricle is relaxed and open. And so that kind of helps the AV valves remain open while the heart is relaxed. Okay. So again, before the atrial systole, all the chambers are going to be relaxed. Blood is returning to the atria, and it's passively leaking through the atrioventricular valves into the ventricles. And then semilunar valves are closed at this point because the ventricles are not contracting. We consider the first step of the cardiac cycle to be the atrial systole, where the atria are contracting. This is also known as the atrial contraction and ventricular filling, how it is described in your textbook. Okay, so during this first part of the cardiac cycle, the atria will contract and they will squeeze any blood that didn't have time to passively leak to the ventricles into the ventricles. So they will just finish pushing the blood that's in the atria into the ventricles. During this time, the AV valves, of course, are open because blood is going from the atria into the ventricles, so the AV valves have to be open. Semilunar valves are closed at this point because the ventricles are not pushing blood through them into the pulmonary trunk nor the aorta, so semilunar valves are closed. And ventricular blood volume would increase slightly at this point because, and we only say that it increases slightly because most of the blood passively leaked into the ventricle already before the atria contracted. So the atria just finish pushing the remaining blood to the ventricles. When the atria finish contracting, this is when your ventricles begin contracting. And the events that are happening at ventricles, we split the ventricular contraction into two parts, and then we split the ventricular relaxation into two parts. The first part of the ventricular systole, or the ventricular contraction, is considered to be the isovolumetric contraction. And the reason for this contraction being called isovolumetric contraction is because the volume of the blood in the ventricle is not going to change. So isovolumetric means volume is not changing. Iso means the same. Remember that ventricles do not begin contracting until atria are completely relaxed. So at this point, during the early ventricular systole, the ventricles are starting to contract, the atria are relaxed, and as the ventricles are beginning to contract, I want you to imagine the relaxed ventricle and how it's kind of coming and closing in on itself, okay? It's squeezing that blood that's in it. And as it's doing this, the tension on the chordae tendineae is being released, and also the blood is being pushed against the AV valves. This is what allows for AV valves to close. So AV valves are going to close during this early ventricular systole, but the pressure of the ventricles on the heart is not strong enough to open up the semilunar valves. So during the isovolumetric contraction of the ventricles, the AV valves are closed, and the semilunar valves are closed as well. So blood is not coming in and blood is not going out of the ventricles, thus the isovolumetric contraction. During this time, this is where we see the QRS wave in the ECG. This is when the ventricular depolarization is going to happen. Eventually, the pressure is high enough to push through the closed semilunar valves, and so now the blood is going to push those semilunar valves open, and it's going to be ejected out of the ventricles into the pulmonary trunk and the aorta. So remember, right side is sending the blood into the pulmonary trunk, left side is sending the blood into the aorta, okay? And the pressure is high enough that the semilunar valves are pushed open. So this is no longer isovolumetric because now we're losing volume of the blood from the ventricles. And so this is called ventricular ejection. So at this point, our atria are relaxed, ventricles are contracting, the AV valves are closed because blood is not going from the ventricles into the atria, and the semilunar valves are open because we're ejecting blood out of the heart into those great vessels, into the pulmonary trunk and the aorta. Ventricular blood volume decreases because we're ejecting blood out of the ventricles. After ventricular systole comes the ventricular diastole or ventricular relaxation. So after the ventricles finish contracting, they begin relaxing. And here we're going to divide this relaxation into two parts as well. So we can look at an early ventricular diastole, which is also known as the isovolumetric relaxation, and then late ventricular diastole, which is atrial relaxation and ventricular filling. So the isovolumetric relaxation is the first part of the ventricular relaxation or ventricular diastole, during which the ventricles just begin to relax, but they're not relaxed enough for the AV valves to open yet. However, semilunar valves close as soon as the ventricles begin relaxing. So at this point, we have both types of valves closed. This is the same as what we saw regarding valves in the early ventricular systole. We also had both types of valves closed. And that's why that part was also known as the isovolumetric contraction. So this fourth step is called isovolumetric relaxation. Isovolumetric because the volume of the blood in the ventricle is not changing. Okay, both of the valve types are closed at this point. The blood volume remains the same in the ventricles, and the atria are completely relaxed and ventricles are just beginning to relax. Eventually, ventricles will relax completely, which would be called the late ventricular diastole. And this is basically the conditions of the heart that we described before we started talking about atrial systole, because this is a cycle. So it is going to be your atria are going to contract, and then they relax, and then your ventricles contract and relax, and then we just repeat the cycle over and over. The figure that you are looking at right now is the figure that was used by our textbook in edition 1. And your figure in edition 3 looks a little different, and it has I believe it has some additional things with it, as well as it's missing the valve graph that is shown here. I preferred this one just a little bit better because it's kind of linear, so when you look at the sections from top to bottom, everything corresponds linearly from top to bottom, and it's color-coded. So, but as far as the information goes, it's very, very similar between edition 1 and edition 2. Now we're going to move into talking about cardiac output. Cardiac output is a measure of effectiveness of your cardiovascular system, and it is equal to the amount of blood that one ventricle pumps in 1 minute. We measure cardiac output in liters per minute. There are several factors that affect cardiac output, and they are heart rate and stroke volume. Heart rate, whenever you hear the word rate, it's something happening over some period of time. So heart rate is equal to beats per minute. So how many beats are happening in 1 minute? And then stroke volume is some kind of a volume. So this is going to be a volume of blood that is ejected during one beat, and we measure this in milliliters per beat. Okay, since it's the volume per one beat. And so we can write an equation for cardiac output that would look something like this. So cardiac output is equal to stroke volume times a heart rate. So using this equation, what this tells us is that cardiac output is a product of the stroke volume and the heart rate. What this means is if you increase stroke volume or heart rate, or both, cardiac output will increase. If you decrease stroke volume or heart rate, or both, cardiac output will decrease. Usually, normal cardiac output is equal to the total blood volume. So if the average amount of blood that we have in our body is about 5 liters, then usually cardiac output is equal to about 5 liters per minute. I would like you to know what cardiac reserve means. And cardiac reserve is simply the increase in cardiac output above its level at rest. So it would be cardiac output at exertion minus cardiac output at rest. So that's the cardiac reserve. This is one of your vocabulary words. So make sure that you know what it is. Keeping this equation in mind, we're now going to look at some things, some factors that influence both stroke volume and heart rate. So the heart rate can be influenced by chronotropic agents. So this one right here would be our chronotropic, this is P, agents. And chronotropic agents, chrono means time, so chronotropic agents are going to affect the heart rate. Rate also means time. Chronotropic agents can be either positive or they can be negative. I'm going to look at them more in detail here, but just to kind of make sure that you understand what the difference is between these two, the positive chronotropic agents are going to increase heart rate. The negative chronotropic agents are going to decrease heart rate. Okay, so we'll look at specifically what each of these are. Now, the stroke volume also has things that are going to influence this, and there are 3 things that, and specifically, that are going to affect the stroke volume. And stroke volume can be affected by afterload. It can be affected by inotropic agents. And then it is also affected by venous return. Okay. Venous return is how much blood is returning to the heart. Afterload in general is going to mean resistance of the blood entering the vessels, and then the inotropic agents are going to be chemicals, kind of, different factors, not only chemicals. The inotropic agents, just like with the chronotropic agents for the heart rate that we saw, are positive and negative. Inotropic agents also can be positive and negative, okay? And here, to kind of give you a big picture here, the positive inotropic agents are going to increase available calcium, and this is going to affect the number of cross bridges because calcium binds to troponin, and the more calcium that binds to troponin, the stronger the cross bridges are, or the higher number of cross bridges there are. Okay, and then the negative ones are going to decrease available calcium, which ultimately will have an effect of decreasing your calcium binding to troponin and decreasing number of cross bridges. Therefore, it will be a weaker contraction. So let's look at some variables that affect the heart rate. So here we said we call these variables chronotropic agents. Okay, so chronotropic agents, chrono means time, and they can be positive or negative. So positive ones are going to increase heart rate, and they can be either sympathetic nerve stimulations or they can be certain hormones. So with the nerve stimulations, this is where your sympathetic axons would release norepinephrine and stimulate release of epinephrine and norepinephrine from the adrenal medulla. Some hormones, thyroid hormone is a very important one. This one increases responsiveness of your nodal cells to norepinephrine and epinephrine. And then some chemicals, okay, these are not hormones, the last three, but they're chemicals that are going to have an effect on the heart rate. And some examples used here are cocaine, caffeine, and nicotine all increase heart rate. So I wrote down how exactly they are going to help with increasing the heart rate. You don't need to go into that much detail. I wouldn't ask you which one inhibits the cyclic AMP or anything like that, but know that they are going to be chemicals. They're chronotropic agents that increase heart rate, that are positive chronotropic agents. Our negative chronotropic agents have the opposite effect. They decrease heart rate. Parasympathetic innervation is our most important negative chronotropic agent, so it has the biggest effect on decreasing heart rate out of all the other things that have a possibility of decreasing heart rate. What the parasympathetic innervation does is it causes opening of the potassium channels in the nodal cells. And if you remember, when the potassium is allowed to flow out of the cell, this is going to bring the membrane potential normally back down to its resting membrane potential, right? However, if we open the potassium channels before that, we're actually going to make the resting membrane potential lower, which means that it will take longer for reaching that threshold of the cell. Remember, like normally in the nodal cells went from -60 to -40, where -40 was your threshold. So if we start with a lower resting membrane potential, then it's going to take us longer to get to that -40 because we're starting lower. And so prolonging that reaching threshold part in the nodal cells is going to ultimately make the heart rate slower. And then some other things that are acting as negative chronotropic agents are beta blockers. Beta blockers are things that prevent norepinephrine and epinephrine from binding to their beta receptors, which normally they want to bind to. And so this will slow down heart rate. Beta blockers are things that we use to treat high blood pressure. And you'll actually see that the negative inotropic agents in that group, we're also going to have substances that are going to be used to treat high blood pressure. For the stroke volume and the substances that influence stroke volume, I'm going to begin with afterload because it's the shortest one. As I mentioned earlier, afterload is the resistance of blood or resistance to blood entering the arteries. So normally, if you are young and healthy and your vessels are nice and healthy, then you don't have much of an afterload, okay? You don't have much of a resistance. However, the afterload and this resistance increases as people age because usually with age, our arteries do get blocked, at least partially or a little bit. And so what that means is the lumen of the artery is going to be smaller, and therefore the heart will have a harder time squeezing all that blood into those arteries because they're occluded. So that's afterload. Inotropic agents are things that are going to affect stroke volume by altering the contractility of cardiac muscle cells. And so as I mentioned in that initial graph that or like a little flow chart that I made earlier, the inotropic agents are going to affect the levels of available calcium. And the more calcium you have available, the more this calcium can bind to troponin, and you will have higher number of cross bridges. And the higher the number of cross bridges, the stronger the contraction will be. So inotropic agents can be positive, which will increase your available calcium and therefore number of cross bridges. and this will ultimately result in a stronger contraction. And the stronger the contraction, the higher the stroke volume is, so you can eject more blood out of the ventricle. The negative inotropic agents are opposites of the positive ones, so they decrease available calcium and number of cross bridges. Some of these negative ones can be certain electrolyte imbalances, as well as drugs that are calcium blockers, and these are the drugs that are used to treat high blood pressure. So the negative inotropic agents are used to treat high blood pressure. Also, the negative chronotropic agents are used to treat high blood pressure. So we can treat blood pressure by affecting the heart rate and stroke volume by decreasing them. The last variable that influences stroke volume is the venous return, and venous return refers to the amount of blood that is returning to the heart. Recall that at rest, most of the blood is found in your systemic veins, because veins serve as blood reservoirs. So at rest, you have a certain venous return, so a certain amount of blood is returning to your heart. This this amount of blood would be changed during physical activity, okay, where you would be redistributing the blood flow, and you would also adding the blood from the reservoirs into your active circulation, okay. The venous return is going to depend on venous pressure, which during exercise, this is going to be quite high because remember, skeletal muscle pumps, right? So during exercise, your skeletal muscle is active and it squeezes those veins and redistributes the blood that's within your body. And also it depends on time to fill the ventricles. So the slower the heart rate is, the longer the ventricle has to fill up with blood. And so it's going to be higher with a slower heart rate. The venous return is going to determine what we call end diastolic volume. When you think about that term, when we kind of break it down, end diastolic volume, it's a volume of blood in your ventricles at the end of diastole. So at the end of relaxation, which means this is right before the ventricle contracts. Okay, so that's end diastolic volume, is the volume of blood in the ventricle right before that ventricle contracts. And the end diastolic volume is going to determine preload. And preload refers to how stretched the ventricle is prior to the contraction. So it determines or it describes the stretch. So it's kind of like if you think about a rubber band and you stretch that rubber band and then you let go. Okay, it's a preload. The more you stretch it, the higher the preload would be. Okay, and remember when we talked about the characteristics of the cardiac muscle, we said that the maximum overlap of thick and thin filaments is when the cardiac muscle is stretched. So the higher the preload or higher the stretch is within the ventricles, the higher the overlap of those thick and thin filaments, and therefore the stronger the contraction would be. So basically what this means is that the more blood that comes into the heart, the more stretched the heart is, and the stronger it will contract in order to get all that blood out. Okay, so this is an important characteristic of cardiac muscle. So Frank-Starling law, this law right here, summarizes all of this together, and it says that the greater amount of blood that enters the ventricle, then the greater the stretch is within that cardiac muscle, and you'll have greater number of cross bridges, and this allows for a stronger contraction and therefore a greater stroke volume. So make sure that you're familiar with the Frank-Starling law and know what parts of these statements belong in that Frank-Starling law. And this would conclude our chapter 19 notes or lecture. So remember, from the cardiac output, we know that cardiac output is the stroke volume times heart rate. Make sure that you know which variables influence what and how. And looking at this equation here, remember that if you increase stroke volume or heart rate or both, cardiac output goes up. If you decrease one of these two or both, then the cardiac output is going to go down. I wanted to point out that parasympathetic innervation, does not have an effect on force of contraction. So remember that parasympathetic innervation is only going to affect heart rate, and that is, it will decrease it. Sympathetic innervation is going to increase heart rate and increase force of contraction. So, but that's something that I discussed on that first video that I did for these notes. So see you next week.